Hello friends, this is a case of unedited, uncut, full length total laparoscopic hysterectomy. Many of my student was asking for the total laparoscopic hysterectomy where there will be no absolutely no cut and it should be completely from the beginning to the end. So, in this video there is no any cut, we have not cut even the time of the cleaning of the telescope also, and all the laparoscopic videos of the monitor is showing here. Outside video here it is not there, port position we are not showing, but the entire operative procedure which is laparoscopically performed is shown in this video, unedited, uncut. So, we can see this is the right side of the adnexal structure is getting separated. We are performing this surgery by the 3 port, 2 working port and 1 telescope. Here we are also not using any infrared ureteric catheter or any ICG, and this will be done without help of any another advanced fluorescent imaging technology. So, now this is left side of adnexal structure and uterus is contralaterally pulled to the 3 o'clock position. Now, we will separate the anterior leaf of the broad ligament. Left hand grasper is stretching the peritoneum, and we will make a lateral window to elevate the peritoneal fold, and it will be separated from left to right, and uterus will be moved to 5 to 7 o'clock position. We can see ureter down there. So, this is the ureter, it is quite lateral, but you can lateralize further by pushing the anterior leaf of the broad ligament more laterally. Now, this is separation of the bladder and lateralization of the bladder pillar. You can see crisscross pattern of the vessel over pearly white vaginal fascia. This is little oozing from the bladder, and that will stop if you will touch with the shaft of the harmonic. Now, uterus is at 1 o'clock position, and this is posterior leaf of the broad ligament. We will not cut the uterus sacral ligament, only the peritoneum will be removed, so that we can skeletonize the uterine artery and we can further drop the ureter down. So, now this is a time to take uterine artery, and for that again we will use Ligasure. Little suction. There are only few drop of bloods, but you can suck it so that vision will be clear. So, this is the left uterine. We can see the tip of the Ligasure is hitting the colpotomizer. That means it is completely skeletonized. So, generally in our practice we coagulate one time either side and then we cut next time, so that there will be proximal thrombus and bleeding will not happen at all. So, right uterine is coagulated. Now, this is the left uterine. You should not go that much lateral, always remain in the boundary of the colpotomizer. We can see that blanching of uterus is started because both the artery is compromised, and now next time we will cut. Now, we will coagulate once more and cut. Ligasure is taken out to just remove the scar, that is the burn particle which deposited. You can clean with the hydrogen peroxide. And little betadine is applied in between the jaw of Ligasure, so that it will not stick with the tissue and temperature will remain within 100 degree centigrade. So, uterine is cut and right side is over. This is the lumen of uterine. Now, this is the right side, left side is cut. Now, this is the right side of uterine, again coagulated and cut. This reverse bleeding, you can coagulate. You can see uterine is bleeding, so you can catch the lumen and coagulate. This is the advantage of proper skeletonization, that lumen will be easily visible if it is bleeding. If it is not, then it will be hidden in the peritoneum. So, both the uterine is secure. And now, colpotomy we will start. So, we are starting with the posterior, just above the vaginal arc of the uterosacral ligament, so that only cervical part of uterosacral ligament will cut. Assistant will give a good cranial traction by the colpotomizer. chances of valve prolapse is less in TLH compared to NDVH or LAVH, and the reason being that you can see that the vaginal part of uterosacral is uncut, and that does not give the chances of increasing risk of prolapse. We are little gentle and slow in this process, because if the tip of the harmonic will touch the colpotomizer, then sometime the ceramic tip of the colpotomizer get damaged. So, you should very gently brush it over, so that colpotomizer will not be damaged. So, TLH part is over. Now, uterus will be removed, pulling through the vagina with the help of tenaculum. That tenaculum is already attached with the Mangeshkar uterine manipulator, and now we will remove the tube of right side. We will only remove the tube, so you can apply on IO ligament. Right tube is removed. This is a stone holding forceps coming by the side of the globes, and inside the globes there is a sponge to pack the vagina. You can see there are some para-ovary and a small cyst, that is better to puncture those, because it may grow bigger in the size in the latter part. However, these are not very important, but it is better to remove it. So, both the tube is removed. Now, we will do the valve closure with the simple number 1 vicryl. This is completely uncut, unedited video. You might not have seen anywhere. We have not taken the telescope out, and any portion of the surgery we have not edited. So, it is a full length video, and that is good to learn all the steps of the surgery. Now, this is the right uterosacral bite is taken together with the vaginal epithelium. It is important to take vaginal epithelium, so that granulation tissue should not form. So, we will suture in 2 layers. First row is unlocked and returning will be locked. Cranial traction is required to prevent any pricking on the bladder. This is again left uterosacral and left vaginal epithelium, and then again anterior, and reaching on the left corner, it is better to lock it. It is retightened. If you have an assistant will hold the tail, but because it is 3 port, so we do not have assistant. So, you have to pull yourself. By the left hand, suture will be pulled cranially, and with the right hand you will keep on taking the bite. So, now final knot will be taken. Here we can see that the needle end of the suture is little small. So, taking a wrap is little difficult. In these cases, better to cut the needle and use tail end to tie the knot. So, we will remove the needle holder, bring a scissors. Little suction of few ml blood which is collected in the cul-de-sac. So, this tail end is bigger than the needle end. So, you will use this to tie the knot. Here we are using simple square knot. First time double wrap was not taken, only single wrap. So, it is not a surgeon's knot, it is a square knot. Now, suture is cut, needle end thread is also held, and everything will come out through the wound. So, thank you very much for watching this video.